Okay, so now we're back. The toxicology lecture, and this one is on decontamination. So this includes some of the general principles we apply to all tox patients. We started this discussion talking about the primary survey, the A, B, C, D, with the D being decontamination, and that refers to the skin and the eye. We put these ones in the primary survey because we wanted to do these things immediately. If there's some sort of toxic chemical on the skin that can affect healthcare workers and continue to affect the patient, we need to get rid of that right away. So remember, we used a mild soap and water to wash this off. And the eye we also want to do quickly because it is so sensitive to these chemicals. You want to wash that eye out quickly, and so normal saline. And this is usually done through a Morgan lens or some other device. And you're going to want to keep irrigating the eye until the pH is about 7.4. You'll remember that if it's an acidotic, so a lower pH, that's going to cause a coagulative necrosis, and alkalotic, so pH is like 7.5, 7.6, cause a liquefactive necrosis, and actually can be very destructive. So wash that stuff off as fast as possible and check the pH and get it down to 7.4. So after skin and eye decontamination, the next thing we want to look at is GI decontamination. And there's actually a lot of ways to do this. And the first thing you may have heard of is ipecac-induced emesis. Syrup of ipecac is this stuff that when you give it to someone, it pretty much immediately makes them throw up. And the idea being that if someone took something they weren't supposed to, maybe you saw a kid take a pill, you give them some ipecac and they vomit it up before there's any toxic effects of it. Now, this really has no place in the emergency room. The only time you might do this is that situation I described when you're at home. In the emergency room, this toxic ingestion had probably already left the stomach. And if the toxin is something that might make them sleepy, the last thing you want them doing is vomiting and aspirating. So in the ER, we are not going to use ipecac. If someone's at home and they call the Illinois Poison Control Center and they say, yeah, you just saw the kid take the pill, go ahead and give him some ipecac and they'll puke it up, that might be the only time I could see using this. Otherwise, we're not going to use ipecac. The next method of GI decontamination is called gastric lavage. And this is what was commonly called pumping your stomach. And the way it's done is by sticking a tube down the esophagus into the stomach and sucking out whatever's in there. So if you have some pill in the stomach, you're not going to just stick some small NG in there, because that nasogastric tube is not going to be big enough to suck up a pill. You need to use something bigger. And so then you stick in these almost garden hose sized oral gastric tubes down in the stomach and maybe wash it out with a little bit of warm water or saline and then suck back up and suck all the pill fragments back into the tube. So we know that an NG tube is way too small and useless in this situation. Now, all the studies have shown that gastric lavage is actually not even helpful. So we don't do that anymore. First of all, after an hour has passed, this pill is probably no longer in the stomach. It's probably into the small intestines, out of reach of this oral gastric tube. Secondly, putting this gigantic hose into someone's esophagus is probably going to make them puke. Again, they're at an increased risk for aspiration. So they'd probably be best to be intubated if you're going to do this. And there's all kinds of complications associated with this, like aspiration, esophageal perforation, hypothermia, and even death. So you know what? We're not doing gastric lavage either. What about plain sorbitol, which acts as a cathartic, with the hope that they'll just poop out all that stuff very quickly and they won't even have that toxin in them anymore. Magnesium sulfate can also be used. Again, this has also been shown not to be useful and might also be dangerous, so no plain cathartics. Alright, how about charcoal? Charcoal has a large surface area and it's very absorbent. So there's lots of places on there for drugs to kind of stick to it and then poop it out. Now, charcoal is very effective, but it can decrease bowel motility and cause eventually a bowel obstruction. So the first dose is usually given with some sort of cathartic like sorbitol. And you got to know, though, what will bind to charcoal and what won't. And the things that do bind are big, complex, sticky molecules. The things that don't bind are the smaller things like metals, hydrocarbons, pesticides, and alcohol. Those small molecules are not going to stick to this, so charcoal's useless with that. You can even give more than one dose of charcoal, called multidose charcoal, with the idea being that the first dose of charcoal is going to grab up any toxin that's in the GI system, and then they're going to poop that out. Subsequent doses of charcoal are now going to create this gradient, pulling toxin that has already entered the bloodstream back into the gut, where it can be bound again by the charcoal and then again pooped out. And this way, each subsequent dose of the charcoal can kind of act like a gut dialysis and pull the toxin out of the bloodstream back into the GI tract where it can be eliminated. Now remember the thing that we said, the first dose can be given with sorbitol. If you give each one of these with sorbitol, you're going to cause such an osmotic diarrhea that they're going to become dehydrated and maybe even become shocky. And again, remember which molecules can be bind to charcoal and which ones won't. The big molecules, big and complex and sticky ones, will stick to it, but the smaller ones like the metals, the acids, the alkalis, iron, lithium, those sorts of things are not going to work, and so don't even bother. Now there's a couple times when you're not going to want to use charcoal. The first is if the patient is altered and you think that they might vomit, because if you get charcoal in the lungs, bad news. The second patient that you're going to want to avoid it in is someone who took a caustic agent. So they swallowed some sort of acid or alkali. The reason here is if you coat everything in black sticky charcoal, when the endoscopist later wants to go in there to do an esophagoscopy or look at the stomach, they're not going to see anything but black sticky charcoal. So this makes endoscopy impossible. The next mode of GI decontamination is whole bowel irrigation. And the idea here is that you're going to flood their GI system with so much fluid so quickly that they're just going to poop all the stuff out very fast. Now, nobody's going to be able to drink that much fluid that quickly, so you're probably going to need to put an NG in. And then through that NG, you're going to give either 1 to 2 liters an hour of polyethylene glycol, or about 25 cc's per kg an hour in kids. That's a lot to drink. And you keep going until whatever comes out the bottom is clear. And that might take about 4 to 6 hours. And so this might be useful for things such as the heavy metals, iron, lithium, and other drugs that really don't bind to charcoal so well. And also it's commonly used for people who have packets of drugs which they swallow, either as acting as a drug mule or in order to avoid detection by the cops. If they got a tummy full of condoms packed with cocaine, you don't want one of those things popping inside of them, so you do some whole bowel irrigation until they hopefully poop all of those out. Now, that wraps up all the methods of GI decontamination. Other drugs have specific antidotes which can be given. I'm not going to go over all of them, but I'll give you a few here. For Tylenol, it's N-acetylcysteine, also known as NAC. For cyanide, it's vitamin B12, or alternatively nitrites and thiosulfate. For iron, it's deferoxamine. There's obviously a lot more, but I'm not going to go through all of them here. And the final method of decontamination that we'll talk about is enhanced elimination. That is, getting the body to get rid of it faster. Forced diuresis, either with a lot of IV fluids or a diuretic, does not help. Hemodialysis is useful for smaller molecules which can pass through the dialysis membrane, and they got to be in the serum. They can't have a large volume of distribution. If the toxin is in the fat or the muscle or some other tissue, hemodialysis isn't going to help. So for fat-soluble benzodiazepines, not going to help. Digoxin or other molecules that have molecular weight greater than 500 Daltons, not going to help. But for smaller things like aspirin, methanol, lithium, ethylene glycol, it can help. So talk to the nephrologist to get that arranged. Alkalinizing the urine, that is making the pH in the urine go up, is a good way of getting rid of toxins such as aspirin, and is done by preparing a bicarb drip. Conversely, acidifying the urine does not help, and can in fact lead to myoglobinuria or even rhabdomyolysis. So don't do it. And the last thing let's talk about is some common rules of thumb for disposition. When is it safe to send someone home? If they're asymptomatic, it's probably best to watch them for 6 hours, just in case they develop any symptoms. Remember, they may have taken some delayed-release product. And if they did take a delayed-release product, like you know that they did, then you better watch them longer, like 24 hours. And if they're symptomatic, obviously, you need to admit them. And regardless if they're symptomatic or not, if this was a suicide attempt, admit them to psych after they are medically cleared. Don't send a patient to psychiatry after watching them for 4 hours, because they could develop symptoms up there and then badness happens. Remember, you need to watch them and make sure they are completely out of the woods. And this concludes our Introduction to Toxicology videos. Let me know if you have any questions or comments. Thanks. Bye.